Hello and welcome to the first session of our Regional Research Education and Teaching Program. I'd like to begin by thanking all of you. The program couldn't have set sail without your overwhelming response and enthusiastic participation. It's been a pleasure organizing it, and we hope that it serves its purpose by helping us all learn a little more about how to carry out research. We understand how daunting it can be, and we wish to make it a little easier for all of us to go about it, especially considering how important it is for our community as doctors and for the rest of the world, and not to forget in advancing our we have a lineup of very experienced consultants and specialist registrars who have done a lot of research over the years and have many prestigious publications to their name. Our first presenter is Mr. Anshul Sopti, a senior trauma fellow who has published numerous papers and also leads a large number of audits carried out in our trust. Our second presenter is Dr. Anjali, an F2 in our trust at the moment with a very strong background of community medicine from India, with a keen interest in research, especially those with a public health impact. She's done a number of clinical audits and studies as well. Now I'd like to introduce our chair, Mr. Ashford, a senior orthopedic consultant with a passion for complex revision surgeries. He leads a very successful program in our trust that incorporates international medical graduates. And under his leadership, the program has been able to produce numerous international publications, posters, presentations, audits. Before we hand it over to Mr. Unithan, I would just like to go over the instructions one more time. Please mute your microphones. Please write in your names as a mark of your attendance if you haven't already. And please send in all your questions on the chat option. All right, over to you, Mr. Unithan.
I'd like to especially thank Tanya for using her Twitter power and also guiding the team to organize this event. Research has always been a daunting field, so we've divided this into various subcategories, which will help to understand research. It's at 9 o'clock on a Saturday. We all have lots of other things to do, but it's great pleasure to see so many people. I think the last count was about 180 people in 180 participants. As suggested, we have produced a lot of work in the last year, and that primarily has directly affected health patient care. So research is also fundamentally to make sure that we treat our patients well and give them the best care that is available. And going forwards, you will be the leaders of the healthcare system in the near future. And as leaders, you've got to make the right decision without the influence of the pharma companies and so on and so forth. Today's two speakers, Anshul has been working in the orthopedic department for years with us, and we published lots of papers together. He's got over 40 papers which he has written. So he's the best person to start this program. Anjali has done a MD from Vellore, which is considered to the Cambridge or Oxford in India. And thanks again for Rahul and Sangamitra for running around and going through all this 180 plus emails. So without further delay, I'll pass it on to Anshul. At the same time, please mute your microphones and text your questions in the chat, and Rahul will look into each questions. Over to you, Anshul.
Thank you. All right, good morning, everyone. Thank you for coming in so early in the morning and giving us your precious time and for the amazing response we have had up till now. I'm going to speak to you today about introduction to research and research methodology. Research methodology will be covered more in details by my colleague Anjali, and she'll describe to you the various study patterns and what they actually mean and how they are run. Before we begin, a small description about the webinars which we are conducting. These webinars are a series of lectures, interactive modules which will run through evidence-based medicine, covering all the research methodology. We will stress upon how to conduct and the differences between a systematic review and meta-analysis. There will be a short introduction to statistics. We obviously can't cover all the intricacies of statistics. It's with special attention to forest plots. This is something which we see very regularly in our articles and in our publications, and we'll try to make it more clear for you. Qualitative research, although we all as clinicians are less inclined to get into this field, but as the world is growing and there's more importance on patient outcomes and patient factors, qualitative research is gaining much importance today. There are very famous last words: publish is a requirement. If you don't publish, you will perish. Therefore, how to write a paper is really crucial to help build your CV and build your research background. We'll also touch upon clinical audits. This is one of the main pillars of our clinical governance, and this is a requirement by all the doctors within the GMC and within your training programs. Finally, some ethical issues within research and publications. It's very important that we understand what they mean and how they affect us in daily life. Okay, so I would request you to please pen down your feedback. At the end of the webinars, we will be sending out survey links. And this feedback is really crucial. Unless you give us feedback, we will not know how to improve and develop further webinars for you. So what are we going to learn today? I'm going to concentrate on the concept of evidence-based medicine or evidence-based practice. Evidence-based practice is now being coined or being called as evidence-based medicine because we all are in the medical fraternity. The nursing colleges call it a bit different, and we'll come to that in a moment. The various steps involved within practicing of evidence-based medicine. The most crucial steps are formulation of a research question or a relevant question. How does one go about that? And once you have a question, how do you look for literature, or how do you search for evidence behind that question? We'll also touch upon the pyramid or the hierarchy of evidence and how this affects what we bring out in the literature or we bring out in our field. And an overview of various research methodologies and methods will be covered by Anjali. So as healthcare professionals on a daily basis, we make a lot of professional decisions. We make professional decisions regarding us and regarding patient care. And we need a lot of information to make these decisions. And how do we get this information? This information is available in the form of evidence-based practice or research. It was initially coined by Saket, who is now termed the father of evidence-based medicine, and he defined this practice as a conscientious, explicit, and a judicious use of current-based evidence in making decisions about the care of individual patients. Now, over the years, from 1996, this has transformed, this has graduated, and in the year 2000, we have Saket by himself changed the definition a bit, and it was more centered towards patient value, because it's an integration of best research and evidence with clinical expertise affecting patient values and patient care. So why do we essentially need this evidence-based practice? This is to achieve a high quality of care within the healthcare system, offer the best to the patient, offer the same treatment anywhere in the world, or in fact, anywhere within the country you travel to. You should have a standardized care. It's also to keep up with the recent advances. For terms in trauma and orthopedics, you have robotics coming in. So you have to keep up with what's the recent literature or the recent advance, and it's a lifelong learning curve, so it doesn't stop. Therefore, we need the evidence-based practice and methods. So evidence-based practice can be subdivided into various steps. As you can see on the screen, it ranges from step 1 to step 5. Step 1, the most crucial, is forming a research question or an answerable question. And once you form the question, how do you look for the research, or you search evidence regarding it? Then you evaluate the evidence. You rather want to implement the effects and the evidence. And once you have implemented the evidence, you want to see how effective they have been. Today, we will concentrate on the first 2 steps because that's the most essential part of a research. Once you have a question and you have searched for evidence around it, you can then form a study, which Anjali will help us with. So formation of an answerable question or an important question or research question, it has essentially 3 to 4 components. And this revolves around a PICO model, also called as the PICO model, which essentially stands for P standing for population, I for intervention, C for comparison if it's relevant in that particular research, and O is for the outcome. Now, what we need to know is that all studies do not revolve around a PICO model. At times, we have to substitute the PICO model into a PIO model or PO model. In terms of PICO, it works very well for clinical effectiveness and intervention questions, whereas a PIO model doesn't work for an intervention. It doesn't need to have an intervention framework. The I stands in the PIO model for an issue, indicator, or an index test. You will note that I have omitted the comparison here. A comparison is not often included, but may also be relevant when we compare diagnostic tests in the PIO model. To understand this better, let's discuss this one research question I have on the screen. Does a febrile seizure in a 6-month-old infant increase the likelihood of them developing epilepsy? Now you would wonder, what's the PIO or what's the PICO model in this? This is the PIO model. And if you look closely, the 6-month-old infant is the population we are speaking about. Febrile seizure is the indicator we speak about, and developing epilepsy is the outcome. Let's look at another example. This is one of my own research questions, what I'm published on. So we are comparing the closed wedge and opening wedge high tibial osteotomies of medial compartment osteoarthritis of the knee in Asian populations and a report of mid-term follow-up. So if you try to now take a few seconds to imagine what's the PICO model or the PICO model on this question, I will show that to you in a second. So that's the question on the top. If you look at the question closely, the Asians are the population we are studying. Intervention is the high tibial osteotomy, which is for the medial compartment osteoarthritis of the knee. The outcome is the midterm follow-up, and we compare two groups, closing wedge versus opening wedge. Coming back to building a research question, it's very essential what question you build, because the question you build decides or influences the type of evidence you want to present. Now, if you're looking at clinical effectiveness of a study, it will be best portrayed by a randomized controlled trial or a systematic review. If you speak about patient's perspective or quality improvements, it is more of a qualitative kind of a study. A diagnostic test or a diagnostic result will get about cohort studies. Moving on, the step 2, the second most crucial part. Now that you have a question in mind, how do you look for the evidence? So the various methods to look for a search for evidence is by manual methods. Then once you have a manual method, it's very outdated now, but there are some articles, there are some textbooks which are not available in online media, and you have to go back to the library to get them in print. Once you have these, you can go through the bibliography or the references and do a further search for relevant articles. The most commonly used method now, which we do on a daily basis, is an electronic search. And on an electronic search, we need to know where to search, how to search, and what is a relevant search once we have a search, what is the relevant evidence on that search. I'll try to make this more clear in the next few slides. The most commonly used electronic media is the CINHAL website. This is more for the nursing background. Medline, Embase, and the most commonly used by us is the PubMed. A search strategy needs to be both sensitive and specific. That gives you a wider concentration of your research. It also definitely needs to be replicable. If it's followed up, or if you do the same search in any part of the world, it should be replicable, giving you the same results. That's very crucial. Now, how does one go about forming a search strategy? In the database searching, what you essentially need to do is break down the question into the PICO model, as I've shown you before. Once you have the PICO model, you can then use individual keywords or combine the keywords, which will increase the sensitivity and specificity of the search. You can also combine words using Boolean operators or Boolean logic or mesh terms. So what's a Boolean logic? Boolean logic is nothing but use of these three important words using and, or not. And essentially brings out results containing both the words you are trying to look for. Or as the word suggests, it will have results of only one of the words, and not will remove the specific term you do not want to look for. Let me show you an example of this. I'll also cover something about quotation marks, that when you want to quote a particular phrase from a citation or a citation, you just use the quotation marks that will help you bring about a better and a specific search. There's something called as truncations. Truncations also allow you to search for words with all the words ending with the same word root. I'll describe to you what a Boolean logic is, its use of and, or not. Let's look at a video to see how this works. Now I'll go back to my own research, have a read about this question, and then I'll try to make it more clear when we run a video. So we're trying to compare closing wedge and opening wedge high tibial osteotomy for medial compartment osteoarthritis of the knee in Asian populations, a midterm follow-up result. So if you can see on my screen here, under PubMed on the search bar, I have entered functional outcomes, medial open wedge, lateral closing wedge of high tibial osteotomy. And what PubMed does is that PubMed has an inbuilt function of using the Boolean operator or the Boolean logic of and. So even if I don't add and, the results coming up is 199 on the screen. Now, if I go ahead and add the word and manually, or use the Boolean operator and manually, you will see when I press search, let's look at the results if that changes into more number of articles or makes it more specific. Not really. So it's brought about the same. This is because of the automatic function of using and. Now what I can do and show you here is, let's change the Boolean operator from and try using or. Before that, I would also like to say that if I cover or, the question I'm asking here is, it's a functional outcome and looking for medial open wedge or lateral closing wedge or high tibial osteotomy. And when I hit search, it brings about 8,000 articles. Now that's a very big search. I need to be more specific. So how can I be more specific? I can be more specific by adding brackets at the start of the medial open wedge and at the end of high tibial osteotomy. And you'll just see in a second how this changes and narrows down the search. So I'm essentially looking for functional outcomes and I'm looking for or between the three words medial open wedge, lateral closing wedge, and high tibial osteotomy. Now here in my second part, what I'm trying to do is I'm trying to change my Boolean operator or into and. So therefore I'm looking for functional outcomes of medial open wedge or lateral closing wedge, but I want to include all the high tibial osteotomies. This should narrow down the search further. And if you see on the screen now, there are 483 where we started from 8,000 articles. Now let's go a step further. Let's try using the Boolean operator word not. And what I'm essentially wanting to do is check for functional outcomes of medial open wedge, but not lateral closing wedge, but including high tibial osteotomies. So there I'm going to change my Boolean operator into not. And if I press search, it's brought about even a closer search. It's brought about 227 articles. And if you closely look at the first two on your results, they speak about open wedge high tibial osteotomies and not of the lateral closing wedge. Coming back to mesh terms, which I described ahead, mesh terms are essentially medical subject headings, which are used to increase the power of any search. It's most commonly used in PubMed, and every article in PubMed is analyzed and then the content is assigned with the mesh term. Mesh terms also helps us to know what the publication type is, the meta-analysis, review, or it's a randomized control trial. Now let's look at an example of how mesh terms work. So if you see on my screen, this is again a video of PubMed Central on my Google search. And within the search bar, let's look for how robotics in orthopedic surgery comes up when I search for it. So if you see here, the results are approximately 877. And once I go through the results, the first article which is brought about is something related to COVID-19. And in fact, it's got no relevance to my topic of interest. The other topics as well is computer assisted. It's not really what I want. I want robotics. And if I keep scrolling down, I can see probably the first relevant article is number 6. Number 7 again speaks about something about e-posters, is not relevant. And you can see number 9 is again relevant. Number 10 is not relevant, and so forth. Okay, so let's try tweaking the search a bit. Now, if I take this off and you break down into 2 parts, robotics is the first part. On the drop-down menu, I go down to specifically mesh terms and I hit search. It brings about robotics searched as mesh term. And at the bottom also shows me what are the various other terms to be used as a mesh term. Now, within the subsections, I am more interested within the trends, instrumentation, and I'm going to now build the search into my search bar. Now, off note on the right-hand corner here, if you look closely, the mesh term is included in the brackets, and the Boolean operator being used in self-built by PubMed is AND. Now, the second part of the question was orthopedic surgery. That's what I enter. And I want to check that I'm looking for mesh terms, and I'm making sure that the left column is again tick mark as mesh. And if I search, orthopedics is a mesh, and underneath they have other mesh terms applicable and the various subcategories. And I'm more interested in looking for trends, the instructions, and probably therapeutic value and surgery as well. So I go down and build on my search builder and add it into my PubMed. And if I press search, it brings out a very narrow search. You would think 5 results is very narrow, but if you look at the results very closely, they all are very specific and sensitive to speak about robotics alone in arthroplasty or in orthopedic surgery. So that's how you use the search on PubMed. I would also like to show you the same search, but on a different interface. This is in different parts of the world, we have PubMed, which behaves a bit different. And if you come across this web-based PubMed interface, let's see how it works here. So if I look for ethics in orthopedic surgery, and if I press search, let's see how many results that comes up with. It's a big number, 3,217 results. And if we closely go down and look at all the results and look at the relevance, probably the first relevant one would be, I would say, number 4. Number 6 is partly relevant. Number 7 is not relevant at all. Number 8, hacking is not relevant. Number 9 is very relevant. This is what I want. And number 10 is relevant. Okay, so let's tweak the search a bit. So if you note, I have pressed advanced options on the PubMed screen bar, and I'm looking for breaking down into 2 words, ethics and orthopedic surgery. I'm making sure I've, from the drop-down, I've marked mesh terms and have looked for the mesh terms which is entered under my query box. And if you see the Boolean operator on your right side by PubMed automatically is AND. I can switch this to make it or not, but that's not relevant in this question. Second part of the question was orthopedic surgery. I'm making sure that on my left screen, again, I have mesh tick mark. And if I press search, it automatically adds that into my query box using the Boolean operator and it's look for orthopedic surgery as mesh. And I say search, it brings out 282. So a very, very narrow search compared to 3,000 articles, which I found first. And if I closely look at the articles, what they are about, if you read through, it says it's ethics related, it's academic influence, it's misinterpretation, orthopedic research on foundation and industry, which is again an ethical issue. And if you see closely, they all are very, very, very specific and relevant to what I would like to search for. Okay, so now once we have that away, going back to truncation marks, which I mentioned before, truncation marks or truncation word roots essentially means that if you would like to search for words which are related to each other, for example, in this on the screen, it says child, children, children's childhood. We can all find them with a simple function of using a word root at the end. So if I say child, if you use an asterisk mark, if you use a dollar sign, a percentage sign, or a question mark, that's the truncation, and it will get all the words related to the same truncation word root. So finally, research either could be quantitative or qualitative. Qualitative research is an extensive topic by itself, and in the next few webinars, we will be covering more on that as well. And this is actually gaining a lot of importance today because everything is centered towards patient outcome and patient function. Quantitative research can be analytical or descriptive, and Anjali will be the best person to describe and explain to you in the next few webinars. Coming back to the hierarchy of evidence or the pyramid of evidence, you see this is a positivist view, and you can see right at the bottom, you have your case reports and anecdotal reports. And at the top, you have your meta-analysis and systematic reviews. Now you need to take this with a pinch of salt. Not all meta-analysis or systematic reviews are at the peak. In fact, some randomized controlled trials or very well conducted randomized controlled trials may take precedence, and they may be higher up above a meta-analysis. So the quality of study included in the meta-analysis and the systematic review is very crucial. So how does one know the quality? So the quality of a study is assessed by the internal validity and the external validity of the study. Internal validity is nothing but a cause and effect relationship. And this is more when you're looking for research or study topics about causation. It is not relevant to all study topics. External validity, on the other point, is valid to all studies because external validity looks at how this study is influenced or it's effective in a wider population anywhere in the world. You also need to know that there's got to be a big reliability of the outcome measures, and these need to be validated scores. I can't take any score I have formulated and try to assess a patient function on that score. It has to be validated by a body before I use that score. Okay, thank you very much. I will now hand over to Anjali to enlighten you about various research projects and the research methodologies.
Hello, everybody. Thank you, Anshul. I just want to confirm, is my screen visible? I'm just going to enlarge it. Yeah, all okay? All right. Great. Thank you, Mr. Sopti. That was extremely informative. I'm sure all of us will benefit from that. So just branching out from his presentation about, he mentioned about qualitative and quantitative studies. So I'm going to be talking a bit about quantitative studies and the designs that we generally have regarding this. Just to introduce myself, my name is Dr. Anjali. I'm one of the F2 doctors currently working with the trust, and I have a background of community medicine prior to joining in here. All right, so just to get you a brief of what's going to be today's talk about, I'm going to give you a bit of an introduction of what exactly are study designs. And then we'll dive in a little more into randomized controlled trials, cohort, case control, cross-sectional studies. So at the end of the session, our learning objectives would be, I hope you'll be able to classify the different types of study designs, understand the basis for the selection of study subjects. So in a study design, how do we really select our subjects, and explain the advantages as well as disadvantages of the various designs, okay? So to be really honest, I think from medical school, the whole concept of statistics and how to really go about it has been very daunting. And I think that's probably because it was very theoretically taught to us. But if we translate it into real practical real life examples, I'm sure it's something which is very relatable and very easy to understand. So I'm going to try my best to make sure that this is kind of like a smooth journey, and I'm happy to take any questions at the end of the session. All right, so let's dive in. So what exactly is a research design? Yeah, so it's a framework where we collect data, we analyze them on certain variables which are specified to that particular research problem. Okay, so I think in today's time, especially in the COVID era, we are part of a movement where all of us are in the race against time to find a treatment, to find a vaccine. And we know I don't think there's any time better than now that we can really appreciate the importance of how much impact research has on patient care and health outcomes. In terms of what are the different types of study designs, we've got descriptive and analytical studies. So this is like a broad classification. Your descriptive studies are smaller studies, so case reports. So you've got an unusual case, it's of an individual case, and when you write that up, that will be a case report. When you've got a series of these or like a group of similar unusual presentations, so they recently talked about how Kawasaki-like disease is very similar, has been coming up now during this COVID season. So a series of those new presentations would be a case series. And under the descriptive, you've got cross-sectional, or in this sense, it would be ecological studies. So let me give you an example. For example, if you've got Japanese immigrants who have now migrated and they are currently residing, say, in the US, and there is, when we study them in terms of their body mass weight, we see that the immigrants, Japanese immigrants who are currently in the US, are more overweight. Usually their population is not supposed to be overweight. So we can try and study if there are any environmental factors which have an impact on that particular population. So when your unit of the study is population, it comes under ecological studies. So this is just a little brief. The main part of our presentation today is going to be on the right-hand side, which is your analytical studies, which are your experimental and observational studies. So let's start off with the analytical, which is your randomized control trial. Okay. So on the left-hand side, as Mr. Sopti rightly mentioned earlier about the various kinds of study that you have, and you can see it's like a pyramid. And randomized control trial comes just below your systematic review and meta-analysis. And in terms of quality of evidence, it really has a very high regard. All right. So let's see what all of this RCT is about. Okay. So what we're trying to do in a randomized control trial, we introduce an intervention and we want to see the impact of the intervention on an outcome, on a health outcome or whatever outcome. So in this context, we're going to take it as a medical RCT, so on a health outcome. It's important that we obviously need to compare two groups, a group which has received the intervention and the group which has not received the intervention. So you can compare and say whether that intervention was actually beneficial or not. It's an ideal design for evaluating both effectiveness and side effects of an intervention. They are both curative and preventive. So by that I mean, now for example, if we want to see by giving aspirin, or by giving a particular drug, is it improving the chances of not developing a disease? So that has to do with drugs or medication or vaccination. So that is curative. Preventive would be by educating a mother on breastfeeding practices. Is it decreasing childhood mortality or infant mortality? So that's more of a preventive measure. So you've got curative and preventive interventions. So RCTs are mainly used for experimenting new drugs, new screening programs, new ways of delivering healthcare, and so many other things. So we're going to make things a bit more easier and easy to understand, we have a hypothetical trial here, which I've named it as a preterm baby trial. We're going to go through the various steps of how we develop this trial. And while we go through it, we'll also discuss about the concepts of an RCT. Okay. So let's take an imaginary country. So this is actually the map of Ethiopia. And fun fact, not really fun fact, but it is a fact that there are quite a bit of high incidence of preterm babies in Ethiopia. So what we're going to do is we're going to put in some intervention. So we're going to take a cohort of preterm babies. We're going to put in some interventions onto these babies, follow them up for a period of time. And then we want to see if any of those interventions actually helped to strengthen and improve the health outcomes of these babies. Okay. So let's see what we're going to do. These are all the babies that we have, say from 2020 to 2021, we take a 1-year period. In the entire country, we take all the babies who are being born preterm. So by that, I mean less than 37 weeks of gestation. Now, the most important key of a randomized control trial is the fact that we are able to randomize our subjects whom we are going to take into the study. So that makes sure that there's no bias when we are selecting these subjects. They are randomly being selected. We're going to take these babies, randomize them, follow them up over a period of 24 months, as I mentioned earlier. Now, if you remember in my previous slide, I said we always need to have two groups. So one group is going to be these babies whom we're going to follow up. Who's going to be your control group? Now, there are various kinds of controls that you can select. So it can be a historical control, a non-randomized and a randomized control. We'll talk a bit about what these really mean, okay? Now, imagine currently I'm taking a group of, say, babies born in 2020, and I'm comparing them with preterm babies born in 2015, say 5 years ago. So it's a historical cohort, a historical control, because you're comparing your current group with a group with similar characteristics, but in the past. Now, what is the disadvantage of this? If I'm doing this kind of a comparison, sometimes, or rather most of the times, there's a difference in the data quality. Now, in 2020, when I'm recruiting these babies into the study, I know that they're going to be for research purpose as well. So I'm going to be very meticulous about the data that I collect, but that might not have been the case 5 years ago. Also, the other thing is there could have been some changes over time from in these last 5 years, which actually have an impact. So that causes a difference between the two groups. So the two groups are not really comparable. So historical controls are not exactly the best. The other group of controls will be non-randomized controls. Okay. So what do I mean by that? What is the problem of a non-randomized control? So we are basically not randomizing. We are not selecting these subjects on a random basis. So what's the problem? So if I have now, for example, in the preterm baby trial, if I know that a particular parent has more healthcare seeking behavior, so they're going to be very compliant with, I'm going to give them an intervention. They're going to be very compliant with the intervention that we give them. In either way, whether we give the intervention or not, just because of the fact that they are very proactive about their child, the child is at a lower risk of a mortality or any bad outcome. So that is what is a selection bias. And that's what non-randomized controls come with, and we don't want that. So obviously the best approach would be randomizing our subjects, because the next assignment is absolutely unpredictable. So let's talk about what that actually is. So when I say random assignment, how do you really randomize these babies? So, okay, so we've taken this entire cohort of preterm babies born during the specified 1 year period. Either you generate random number tables. So say baby number 1, baby 11, 20, 16, random number tables, which are generated, that can be computer generated as well. There's another way of selecting these subjects. So what we call as SNOWs, which stands for sequentially numbered, opaque, sealed envelopes. Okay, so let's break that down. So on the right-hand side of my slide, you can see, so there's a hospital, there's a baby born there, preterm baby. Now the hospital has been recruited for the purpose of the study. The person in charge calls up the research center, tells them, okay, baby number 1 is born, please give us a number. They will allocate an envelope saying, okay, envelope number 1 is for this baby. In that envelope is which intervention the baby is going to receive. Intervention A, B, C, D, whichever intervention the baby is going to receive. So this way it prevents any chances of an unintentional bias. So sequentially numbered, opaque, sealed envelope. So it's a sealed envelope which is opaque, and they are numbered in a sequential manner. Each of those envelopes have these intervention groups, and we're just randomly handing over an intervention to each baby. So that prevents a bias. So in this way, neither the parents of the preterm babies know which intervention they're receiving. The person who's giving the intervention, for example, the healthcare worker, is not aware which intervention they're receiving. And even the person who's sitting in somewhere else who's allotting these interventions doesn't know whom they're giving the intervention to. So in all sides, what is called as a blinding. So single, double, and triple blinding is what I just explained to you right now. Okay. Now, one of the things that it's very common, to get confused is what is the difference between randomization and matching? Okay, so why randomize and why not match? Now, matching can be done only for variables that we know about. Okay, so I can take two groups and say, okay, let's take everybody who's a female, or let's take everybody who's an adult. So you can match things which we know of, like age, sex, residential status, etc. you cannot match things which we don't know of, like genetic constitution of the baby or say immune status of the baby. We can't match for those things. So randomization actually helps in this kind of a situation where you can't um, account for variables which you don't know about. So that's why we need to randomize and not match when it comes to an RCT. So these are our intervention groups. We've got the control group, intervention 1, 2, 3, and 4. Okay, so let's see how our babies are going to come into the funnel. They'll talk to the hospital authorities, will talk to the center will allot them a number, and in an extremely random manner, the babies are given, the various intervention groups, and no one is aware about which baby is receiving which group. All right, so let's go into our preterm baby trial again and talk about what these interventions are. So on the left hand side upper part of the slide, you can see intervention 1. That's a picture of a mother giving kangaroo mother care. So that's something that we've all learned in pediatrics, which is supposed to be improving the outcome for preterm babies, helping them with their birth weight and growth. So one group of mothers or babies received this intervention. The second group of babies received advice on breastfeeding, and they had home visits by healthcare workers to actually weigh the babies over a period of 24 months just to see how their growth is. Group 3 received all of this. So they received KMC, kangaroo mother care advice, breastfeeding advice, home visits, like complete comprehensive package. And a control group which did not receive any of these interventions. They just received standard care. So what we're trying to do here is we've introduced these interventions. We're going to follow them up over a period of 24 months and see how it has an impact on improving the health outcome of these babies. So we basically study the interaction between each of these interventions. And this kind of a design of an RCT is called as a factorial RCT. We're taking into consideration every factor that comes into play in improving the health outcome of these babies. Now, sometimes, like when we started off earlier, we said that, okay, we're going to take all the babies from Ethiopia. Now I decided, okay, you know what? Let me just categorize based on neighborhood or say based on villages. So I'm randomly selecting villages and I take say 20 babies from each village. This kind of a trial where you're taking from every cluster is called as a clustered RCT or a cluster randomized control trial. When is an RCT really suitable? Okay, so obviously we need to have a large sample size. If you've got a really tiny sample size, your results are really not going to show anything. So you need to have a massive sample size. You need to have very clear and measurable impacts. So when you are introducing an intervention, you should be able to measure whether that intervention actually did something by the end of your study period. So at the end of 24 months in our preterm baby trial, we will be able to see, okay, has breastfeeding decreased the mortality by say 50% or say 25%. So it should be measurable and it should be very clear. The other thing about an RCT is you need to plan very clearly before the beginning of the intervention. You can't reach midway 1 year into the intervention and say, okay, you know what, let's do this as well. No, because you've already assessed a good number of babies for the first 1 year. So planning before the beginning of the intervention is a mandatory thing for an RCT. Let's talk about when an RCT is not suitable. Obviously, when quicker results are needed, you can't do an RCT. And when lower units of analysis, like I mentioned earlier, large sample size, so this is the opposite of that. When lower units of analysis are available, you can't do an RCT. So this was a bit of a summary of an RCT. To be honest, there's quite a bit more in detail about analysis and statistics related to each of these studies, which we will be talking about in the further webinars. Let's go on to cohort studies. So that was the other, so under the classification, under the descriptive studies, we've got the cohort, cross-sectional and case control studies. Let's go to the cohort first. So the point of a cohort study is to mainly elicit if there was any, causal relationship. Okay. So in a cohort study, the main thing that we need to know is you don't start with the disease. You start with the exposure factor. You take two groups of people who are exposed and not exposed, and then you follow them up in the future and see how many of them developed and didn't develop the disease. Again, comparison is a key in a cohort study. Now, if you remember, I mentioned that in an RCT also, we need to have a comparison group. So the question comes, what's really the difference between a RCT and a cohort study? Because you're comparing two groups either way. So for example, in an RCT, we want to see if a particular, say, aniline dye, does it cause bladder cancer? So you're seeing all people who have been exposed to aniline dye, and in the future, you want to follow them up and see if they develop bladder cancer. Now, if it is an RCT, you have to introduce the aniline dye as an intervention. So you're going to tell the individual, okay, I'm going to expose you to aniline dye, which I think is carcinogenic, and I'm going to follow you up 10 years from now just to see if you develop bladder cancer, which is absolutely unethical. So you can't do that in an RCT. So that's one of the differences between a cohort and an RCT. The other difference would be cohort studies are not randomized. So your subjects that you're taking are not based on randomization. So let me give you an example of that. Now, on the right-hand side, you can see a factory worker. He's got sickness, say asbestosis, okay? Now, all the workers in that factory, or say majority of the workers in that factory have asbestosis. Now, we don't know, and all of them happen to be living nearby or in the same neighborhood. Now, we don't know if they have developed the asbestosis because they work in the factory or because they have picked up something from the neighborhood. So there's an absence of randomization over here, which is another differentiating factor between a cohort study and a RCT. So as I mentioned earlier, we start with people who are exposed and non-exposed, which you can see on the vertical column here. And we follow them up in the future, and we see how many have developed the disease and how many have not developed the disease. So in this case, the number of people who've developed the disease would be A. So this is among the exposed, A by A plus B. And the number of people who have developed the disease among the non-exposed would be C by a total of the non-exposed, which is C by C plus D. This ratio of the exposed by the non-exposed gives you what we call as a relative risk. Now, relative risk is a measure of cohort study. All I want you all to know at this point is that it tells you whether, if your relative risk is greater than 1, it tells you if there's if there is a positive association. Okay, we'll get into the details of that in the following webinars, but all I want you to know right now is relative risk is a measure of association when it comes to cohort studies. Now, just like we discussed, how do we select study subjects when it comes to an RCT? It's important to know how do we select study subjects when it comes to a cohort. All of us are going to be doing cohort studies, if you're interested at some point. And when you're starting off the study, you need to know, how do I really select my subjects? So there are mainly 2 ways of selecting subjects. So one is where you're starting with the exposure. Okay, so let me give you an example. You've got an antenatal woman. So a group of antenatal women who've probably had intrauterine, who probably had radiation exposure. So their fetuses have had intrauterine radiation exposure. Once the baby is born, you follow up the babies and you see if they developed cancer, have they developed any other health problems. So you're starting with the exposure here and you're following them up in the future. The problem with this is you can study only one exposure. The only exposure you can study here is intrauterine radiation developing into cancer. The other type of picking up subjects is identifying a group prior to the exposure. So there's a very famous millennium cohort study, which was done in the UK from 2000 to 2001. What they did in this study is they took around 18,000 babies born in UK during this period. At this point, the babies are just born. They don't have any disease. They don't have any exposure factor or anything. And you just follow these babies up at, say, 1 year of age, 5 years, 10 years, 15 years, 20 years. So you're following them up and you're seeing the multiple exposures and the multiple diseases that these babies develop. So that's the main difference between starting with the exposure and starting with prior to the exposure. So retrospective and prospective cohort study, these are terminologies that we've heard a lot. It's always a bit confusing. So this is a just one slide which I thought would be really useful. So let's imagine we are in the present now. So the present is say 2004. Okay, imagine we are in 2004. Now, if I do a study from 2004, okay, I'm defining my population. In 2014, I have identified an exposure and I'm following them over a period of 10 years and seeing whether they've developed the disease or not. Okay, so this is going ahead in time. And this is a prospective cohort study. Like we discussed earlier, we are starting with the exposure, following them to see the outcome, and we are progressing ahead. So that's a prospective cohort study. Let's see what's a retrospective cohort study. Okay, so I am in 2004 right now. I decide, let me go 20 years back, which is in 1984, define a population, say nurses, okay, follow them up over a period of 10 years. And in 1994, I decide the exposure, say how many nurses are taking contraceptions. I mean, female nurses. Okay, so how many nurses are taking contraception? And then I follow them up 10 years later to see how many actually developed breast cancer. Okay, so I'm still in the present, but I've taken records from 20 years behind me, seen their exposure factor, and seen as of today how many have developed breast cancer. So that's a retrospective cohort study. It's still proceeding forward, but it's just back in time. Now, there is a combined cohort study, which is a mix of retrospective and prospective. So I can be in the present. So I'm in 2004. I take records from 20 years before, so 1984, okay? And I follow them up in the future. So 20 years from now. So from now to 2024, I follow these nurses up and see, have they developed breast cancer? So you're taking a previous record, which is retrospective, and from today, you're going ahead in time, which is prospective. A mix of both of this is what we call as a combined cohort study. I hope this was clear. It can be a bit confusing. Apart from the timeline, one other main difference between a retrospective and a prospective cohort study is in terms of when the exposure begins. So if I'm in 2004 and I'm doing a prospective cohort study, my exposure is in the future. My exposure has not come yet. It's in 2014. But if I'm doing a retrospective cohort study, the exposure has already happened because the exposure happened in 1994. So that's another difference between a retrospective and a cohort and a prospective in terms of timing of exposure. Cohort study obviously has a couple of disadvantages. Now, if I'm taking, say, nurses in 1984, and I'm going to follow them up over a 20 or a 40-year period, it's an extremely long duration and it can be very expensive. Sometimes the investigators even may not survive till the end. You can have a high loss to follow-up rate. So I would have started with, say, 10,000 nurses, but for whatever reasons, maybe they refused to be part of the study, maybe they died, or for whatever reasons, they are falling off the study. And by the time I'm analyzing them, say 20 or 40 years later, the number of people I'm analyzing are very less. So it's got a high lost to follow-up rate. That's what we call that. Sometimes the findings may no longer even be relevant. So 40 years ago, I wanted to see if contraception causes breast cancer, but now I don't have to wait for 40 years. I already know that there is a risk of contraception and cancer. So the finding is no longer relevant to me. And sometimes new data may not be available. Another disadvantage is a bit of a bias here. Okay, so let me give you an example of what exactly is an information bias. Okay, so as you guys are aware, recently with the COVID, it's been proven that COVID is more likely in your minority and your ethnic groups. Okay, so if I'm a radiologist, if you can see my image, I'm a radiologist. I am viewing an X-ray, and in the patient demographics, in ethnicity, it says Asian, for example. Now, in my head, I'm looking at the X-ray. It's just query COVID. So the doctor has reported it as query COVID. When I'm looking at it, not really COVID-like pictures, but knowing the fact that this X-ray belongs to an Asian a person of an Asian ethnicity, in my head, I'm thinking, okay, you know what? Maybe it is COVID because the chances of COVID in them is higher. So this creates a sort of bias based on the information that I have that this patient is Asian or belongs to an ethnic group, for example. So this is an information bias. And as I mentioned earlier, there's a good loss to follow-up rate. So not exactly the best. I mean, it's quite a bit of a disadvantage. Going quickly into the next set of studies, which is your case control studies. So in contrast to what we had in the cohort study, in case control study, we start with the disease. So you divide it as cases and controls. So cases would be people who have the disease, controls who people who don't have the disease, and you go backwards and see were they exposed or were they not exposed. Okay, so once again here you need to have a comparison group. The most important thing that you need to know in a case control study is that cases and controls should be very similar to each other, except for the fact that cases have the disease and controls don't have the disease. You should try and make them as similar as possible, say age, gender, neighborhood, ethnicity, whatever. As much as possible, they should be similar so that you can actually study the difference between people who have and who don't have the disease. So that's what we call as matching. So on the right, I've just given a small example about, cases and controls and how we really divide them into our little 2 by 2 table. When we talk about case, so how do we really select these cases? So you got the case. How do we select these cases? Okay, so either can be selected from the hospital. Sorry, I think someone isn't muted. That's causing a bit of a disturbance. Yep, thank you. Okay. So either we select these cases from the hospital. Okay. Now, what is the problem with selecting the case from a hospital? Now, you've got only very sick people go to the hospital, right? So you've got a very sick person going to the hospital and you select all the cases of lung cancer admitted in the hospital. Now, the disadvantage of this problem is any risk factor identified, okay, can be a risk factor only in severe forms of the disease. So you may have forms of the disease which may be mild, which may be moderate, and these people are not coming to the hospital. So we're losing out on that share of the people. So that is a disadvantage when it comes to selecting cases from hospitals. When you're selecting controls, one of the things that you need to look out for is, so let me give you an example. You want to see how many smokers develop lung cancer. Okay, and I've got patients of lung cancer in the hospital. I want to select a control group and I decide, okay, let me select all the people with emphysema. Now, the problem with that is smoking can also cause emphysema. Smoking can also cause lung cancer. When you're studying these two groups as cases and controls, you're not really going to see too much of a difference in terms of your studies. So the factor that you're studying, which is your exposure factor, which you're looking at, that is smoking, should be as minimal as possible in your control group. Okay, so you should take a person who has lesser chances of smoking if you really want to see if that smoking has an impact on lung cancer. So that's the main thing about selecting cases and controls in a case control study. So like I mentioned, choose controls with the least chances of having the exposure. Now, the disadvantage of a case control study is something what we call as a recall bias. So you've got two kinds of bias there. So what's a recall bias? For example, there's a woman, she's got a baby with congenital malformations. Okay. If you ask her, and this was not expected. So if you ask her every detail about her pregnancy, she's going to remember even the smallest of URTI that she had. Yes, I had a viral fever for one day. Yes, I had a rash for one day. Could that have been the reason? Because she's going to remember every detail. On the other hand, if you see a woman who has a normal baby, she's not going to remember the fevers and the UTIs and all of that she had because the baby is normal. So she's not trying to think where this actually came from. So this is called as a recall bias. So when we compare cases and controls in this situation, the cases will be able to remember more information as compared to that of the controls. Another bias that is seen in case control is a misclassification bias. So where like I've shown in the image here, you've got exposed and not exposed, and you've got cases and controls. If you can see, there are some cases by mistake gone into the non-exposed group. And there are some some controls gone into the exposed group. So basically there's there's like a mixing which happens. So that's what we call as a misclassification bias. So what are the advantages of a case control study? They're definitely less expensive compared to a cohort study. It's of a shorter duration. It's very good to study rare diseases because we're starting with the disease, isn't it? We're starting with the disease, going back and seeing were they exposed or were they not exposed. So rare diseases, it's a very good study and generally lesser logistical difficulties. My last slide would be on cross-sectional studies. So if we want to study, so it's about something which is occurring simultaneously. Okay, so if we want to study what are the chances or what is the prevalence of an elderly woman developing osteoporosis. Now, the elderly woman and the diagnosis of osteoporosis are both happening at the same time. So it's like a snapshot, and you're just seeing, is there a higher risk if you are elderly and if you are of a female gender? Are you at a higher risk of developing osteoporosis? The disadvantage of this kind of a study is you can't really make an understanding in terms of the time. So you don't know when this really developed. So a temporal association or a causality as to what exactly caused that osteoporosis. Was it the fact that she was female and elderly, or was it her nutrition? Was it something else? A causality can't be really made over here. But the advantages is that it's inexpensive, it's simple, and I'm sure all of us have done very simple cross-sectional studies because it's definitely more easier to carry out. But in terms of quality of evidence, it's a bit more down in the pyramid. So, and that's just about a small, 2x2 table on cross-sectional studies. So that's all I have for today. These are my references from which I've taken, all my content from. I hope I've made the entire idea less scary, at least, and I hope you'll have gathered some information and be able to use it. So thank you all for listening, and we're happy to take any questions. And I just want to let out a special thanks to Rahul, Sangamitra, and everybody who's facilitating this. I think it's a huge task, and it's an amazing effort from everybody. Thanks.
Okay, guys, thank you. So I'm going to start with some questions that I've received from people. And I'm sorry if I don't get to your question, but I'll try to get to everyone's question. Now, there are some ethics questions that were asked. I think we'll just let the speaker on ethics answer those questions before we go into the ethics part of the research. One question that was asked that was not related to ethics was, in prospective studies, while we're following a single exposure factor, what if one of the subjects develops another risk factor, which could also contribute towards the outcome we're looking for? What do we do then? Would you like me to repeat the question, Anjali? You're muted. Anjali, you're muted.
Yeah, can you hear me now?
Yeah, please go ahead.
Yeah. Thanks for that question. So I think what I understand is, in a prospective study, we're looking at one exposure factor. We are following them up in the future. And if that, during that period, if they develop another exposure factor, which could have caused the disease, I think that's what the question is.
So then what is the outcome that we're looking for?
Yeah. So the main thing is, obviously there are certain things that we cannot avoid, but when you're planning a study, it's very important for us to, like I said, everything depends upon the cases and the controls. I mean, basically everything depends on the subjects that you select. So it's very important for us to ensure that we have clearly defined our exposure factor and our disease factor, and try to select subjects in such a way that the chances of them developing another exposure factor, which could have caused the disease, is very, very slim. It's all about selecting these subjects. Still, we can't avoid these kind of things. So we can include them. We will include them in the study, but not in the main analysis. It would be like a subgroup analysis. But then again, it's one of the bias. It's one of our limitations, and we can't really do much about it. But in terms of trying to prevent it, all you can do is to make sure that there's a good difference and a classification between these two groups before we start the study itself. I hope that answered your question.
Okay, and the next question, Anjali, is what is a confounding bias?
Yeah. So it's basically about a confounding, so something which could be a confounding variable. Okay. So let me give you an example. We've got, so it's a known fact that in a high altitude, so people living in high altitudes are known to be hypothyroid. Okay. Now we don't know what exactly is the cause of it. Um, One of the so people in the high altitude are also nutritionally deficient for iodine. So that's one of the reasons. And then, so we don't know basically where what do you say, where is it really coming from? Is it because they're nutritionally deficient, or is it because it has to do with the fact that they are in a high altitude? So so a confounding variable is basically something where you know an exposure factor and you know the disease, but you also know that these group of people can be subjected to another variable which you can't really control. So that would be a confounding variable.
Okay.
And that could
And I,
confound.
sorry, if I can interrupt, Anjali. Just going with my colleague, I think the main thing that she was trying to portray there in terms of confounding bias is based on, there's two questions that were asked regarding exposure. You're studying one risk factor, and then the presence of two or more risk factors within an individual or within the cohort, those become your confounding variables, which you will account for when you're doing your analysis by doing a subgroup analysis to see if there is any association between the said risk factor and the outcome that you're trying to study for. And I just want to say this because the next question asked by one of the participants was along the lines of COVID-19 and how WHO has skipped on certain risk factors as being contributors to death, other than the COVID-19 itself, and how we're attributing COVID-19 to or the Asian background, and maybe they have other, maybe immunocompromised, or maybe something else that was added to the risk factor group. So in any study, there's always going to be confounding bias, because you're going to have some sort of a risk factor that's a hidden risk factor that as you're conducting the study, you're going to get to know. So that's where your subgroup analyses and your matched cohorts and all of these come into play. I think Mr. Sopti is going to answer a part of this question as well.
The only thing I would like to say is that, obviously, like Rahul said and Anjali said, there are going to be confounding factors in any study. Now, it all depends on your study design. Now, if your study design or your aims or your objectives are very, very stringent from the very beginning, and your inclusion and exclusion criteria are very specific. If you have an exclusion criteria which says that if I find a second confounding factor, maybe a third confounding factor, I will eliminate that person from the study. So that's where your study design is very important. And yes, there are going to be confounding variables, and they can form confounding factors and affect your study. Therefore, you may want to take them out or leave them.
Okay, and just a couple of questions, I think, for everybody's attendance that I'm going to ask, because there was an earlier question in terms of during randomized control trials, what happens to individuals who are, say, for example, in the intervention group, and they develop, side effects or, disease from the intervention being given. Or if they're in the placebo group, their disease progression happens. Ethically, Anjali, if you want to explain briefly what a crossover, is, I think they will understand better in terms of what happens during those ethical scenarios.
Yeah. Can you hear me?
Yeah, please.
Yeah, thanks for that question. So that's something which is expected. And in fact, when you're introducing an intervention, you just don't want to study whether it has a positive or a negative disease outcome, but you also want to study what are the side effects, what are the adverse effects, and everything. So that's what we're trying to do. Even when you're introducing a vaccination, it's not just about, how many people have been treated from or prevented, how many diseases have been prevented, but you also want to see if it has a side effect, long-term effect, and all of that. So yes, that's going to be it's going to be one of the parts of the study. As Rahul mentioned earlier, so what we call is a crossover trial, what they do is, so you've got a planned and an unplanned crossover. So in a planned, what they do is they take two groups. You've got an intervention, you've got group 1 and group 2. You give the intervention to group 1 and group 2 is the control. You follow them up over a period of time, say few years or whatever period of time, and then you cross over. So now group 2 is receiving the intervention and group 1 becomes the control. So in this way, you make sure that everyone has received the intervention and everyone has remained the control at some point. So that's a planned crossover trial. This is already planned at the start of the study. Sometimes what happens is it's an unplanned trial. So you've got an intervention and you decide, okay, this group of people require medical treatment and this group of people require surgical treatment. Now, for whatever reason, if the medical treatment is not really helping, a group of in the medical treatment cohort, say 100, say 10 did not suit medical treatment and now they need to receive surgical treatment. Okay, so from the 100 medical treatment, 10 of them are receiving surgical treatment. And similarly, out of the 100 people who are planned for surgery, 10 of them refuse and say, no, we want medical treatment. Okay, so that's an unplanned crossover. That is normal, that's going to happen. And there are various types of analysis that you can do. Terminologies like intention to treat analysis and everything. There are some terminologies for that. Basically, we'll just analyze separately. Analyze people who were intended for a particular plan of management. So, and then you analyze people who actually shifted from medical to surgical and vice versa. So you just analyze them separately and you have a different group. I hope I've answered that.
And I think we have maybe a few minutes for just a couple more questions. So guys, there's a lot of questions that are being asked in terms of the ethics involved in research. And ethics is a very huge topic to be covered by one person. I think we'll let the speakers that have scheduled their talks on ethics in research to answer the ethical part of these things. Before I ask the question, to quickly address the ethics part of it again, there's a question that is essentially someone's asked that boils down to, if you're studying a risk factor and you know that it causes a certain disease in a group, and if you're going to follow them over a period of 10 years, are we morally or ethically obliged to inform them, that this is happening? And I think, again, I'm going to leave that to the ethics part of the talk to be answered. But briefly, there are many different things that play a role in this, because A, if it's a public health issue. B, is it one of those things whereby, are you creating some sort of a bias or something else into the study that you're doing by interfering with a certain thing, or is it a modifiable risk factor? And how can you, and the third one is, how are you, if you're studying an association, how can you say before your study is completed that there is a clear association? Again, ethics say that if you found a clear association, then maybe you should terminate your study prior to and publish your results, and then go from there. Now, Anjali, just going back to the randomized control trial principles, I'm sure you've talked about it, but if you haven't, block randomization and 2-to-1 randomization, were, just briefly 1 or 2 sentences on those. What is block randomization and what is 2-to-1? Just briefly, so that everyone's aware, and then we can move on.
Yeah. So it's basically where we, randomize the groups. I'm not sure how to make it very simple. Randomize groups into in terms of dividing, in terms of a ratio. So let me give you an example. So if we are, let me talk to you about, say, so for example, stratified randomization. Okay. So what we do in stratified randomization is we're basically dividing your group of subjects into layers. So like, let's take the example of the preterm babies that we saw. So if we are dividing them into, so sometimes what happens is there's a chance of, even if it's randomized, there's a chance that there are too many sick babies in one group and too many healthier babies in the other group. So if we stratify them in layers, so we say, let's take babies based on their geographical location, so urban and rural babies, and then we further divide them into very sick babies and healthy babies, and then we take proportions from these groups, so equal proportions from these stratified groups. That will give us better mix of subjects in each of your control groups. So that's what we basically do in in a stratified randomization.
Yeah, fine. Now, just to conclude, and then I'll hand over to Mr. Sopti, who has a few parting comments and things to say in a second. So essentially, the one thing that I thought I should mention before we close the talk is, from a surgical point of view, most of the times, if we're doing a surgical planned treatment in randomized controlled trials, because of the ethical issues involved, it's always going to be not double blinded, it'll be single blinded, because the surgeon's going to know, operating surgeon will always know what operation or intervention that's being performed. So we should just keep that in mind for those interested in a surgical research and randomized control trials. But otherwise, I will hand over to my senior trauma fellow, Mr. Sopti, who will do some parting message for us. Please, thank you.
Anjali, do you want to unshare your screen, please? Okay, so I just would like to share this one service from our library. This is called the Knowledge Service, and it supports a lot of literature searching and evidence seeking. We will send this flyer out along with your certificates once you return back our feedback forms. This is essentially to find all the possible systematic reviews in the various databases. It also talks about what are the healthcare databases and in what branch it's more useful for. And when you don't have access to full articles, how these databases can be accessed, or how this service can be used to get full access for them. There's something called as Athens, Open Athens, and you can register for this on the link here. And I'm sure the person in charge, Alison Paul, she'll be very helpful and will coordinate with you and instruct you further steps. Also, finding the full text, this service helps you to get a lot of articles once we don't have access to all the paid journals. And when we need the articles for our publications, we use this service very regularly. They're great help, and I think this will help all of us develop more. Okay. All right, so I would like to please conclude this webinar and take the opportunity to thank our mentors, Mr. Unithan, who's in charge of the International Medical Graduate Program in our trust, and Ms. Tanya Sakal, who's our college tutor. Without their support, this would not be possible. Also, big thanks to Sangamitra, Dr. De, and Dr. Gade. Without their endless nights they've spent in organizing this webinar for you, coordinating with all the participants and arranging this for us, it would not be possible. Thank you, Anjali, for your very enlightened lecture. It's made so much more clarity now. Topics which I never understood. It's very, very clear now. Thank you for that. Thank you guys for joining us. Have a good rest of the day, and see you soon in a couple of weeks. Thank you.